Dr. Abha, do you wanna start, and we can go through the questions that we asked Regina.
Totally. Regina, what we want to do is talk about patient safety from a personal perspective and also understand what's happening in your home country of Uganda so that we truly have a global perspective about patient safety. To start with, can you think of a personal story, either related to you or someone you know, that brings the human face to the patient safety situation around the world?
Yeah, thank you very much. The personal story is actually about my mother, who almost died due to an overdose of her hypertension drugs. She was taking a medication which was one times one, but then one time it was prescribed as 1 times 3. So my mother had very many different conditions. She had hypertension, asthma, diabetes, and she had all these medications. So poor woman had no idea sometimes to be able to know. She was 60 years then. She passed on, unfortunately, later. But she had all these medications, so she would not have known whether a mistake had been done. But then my nephew, who had gone through health literacy training and medication safety, was able to identify that his grandmother had been prescribed a higher dose than normal. So he was able to identify the problem, and then my mother did not take the medication. So it was a near miss incident that was helped by a nephew who had health literacy. I've shared this story with WH, and it's documented. So in my work, I've interfaced with these near harm incidents at personal level, at family level, but also at community level, seeing what's happening. Yeah.
Thank you. Dr. Alhawsawi, may I ask another question as we go to the key harm areas? If you can give us a general, very brief overview of the healthcare situation in Uganda, hospitals, private, government, insurance, how many hospitals, typically what's the overall landscape of healthcare in Uganda as you see it?
I can say that the healthcare in Uganda is majorly provided by supposed to be by government, but I must say that the healthcare system is dysfunctional in a way that many people that are mainly in the rural areas, the disadvantaged, the marginalized, actually do not receive the care that they need. We have issues of accessibility in terms of distance, availability, and affordability. Most of the healthcare is provided almost 60% by the private sector, which is very expensive, and many people actually use out of pocket for their health care, which is again very expensive, given that many people are living below $1 a day. So it's very difficult to afford health care. Besides, there is no control over the charges for private sector. You realize that during COVID-19, poor people were being charged thousands and thousands of dollars, to the extent that even when people died, their bodies would be retained in hospitals because they couldn't pay for that money. And again, health insurance, we do not have a national health insurance in Uganda, which also impacts accessibility, because people pay out of pocket, and this exposes them to, first of all, very expensive healthcare, but also they're being taken advantage of by private sector, which has commercialized healthcare and results in unnecessary procedures being performed, polypharmacy giving you medications because that's what they have to make sure that you pay more. So patients are not protected, and as such, they stop going to the facilities and either stay in the communities and die, or go to traditional practitioners who are cheap, very accessible, and also the relationship is really good. Then there's the whole issue of access to medicines. It is mainly provided through the national medical stores, which the government structure. But again, in terms of trickling down to the communities, we have many drug stockouts, and which again impacts affordability, but ultimately it also impacts patient safety.
Absolutely. Thank you.
Well, Regina, to build on that, so in your perspective, and we know that this may be colored a bit by COVID, but in your perspective, what would be the top 3 harm areas in Uganda? And you can, if you want, you can talk about it pre-COVID and during COVID, if you think that this would be helpful.
It's pretty much the same pre-COVID, but of course, COVID has heightened the challenges that we already had. But the top 3 is medication errors, diagnostic errors, and hospital-acquired infections. Yeah, and these are basically because of the extent of the problem. And as a result, because when you look at the medication errors and diagnostic errors, they're kind of interrelated. We have so many unqualified, ill-trained healthcare professionals who are not really updated, having so many mushrooming medical training training schools. So, and as such, we have many of these in the system. So as a result, then there are also those ones that they're qualified but do not update, their information. They don't use clinical guidelines because of the big numbers, the work overload. So that brings in the problem of diagnostic errors, which also lead to the medication errors. And then, of course, the hospital-acquired infections, or the system is not, there are so many system challenges in regard to, trying to be able to avoid the hospital-acquired infections, which at the patient level, but also the systems level, in terms of the strengthening the system itself, but also lack of the basic supplies in these hospitals. You'll find that there are no gloves, there's no running water, there's no electricity. Just those basic supplies expose the patients to to those situations.
So if you have a magic wand to deal with those 3 areas, what would you do? From your perspective, if you have access to resources, how would you think this could be rectified?
At the moment, actually, we at the community level, the work that I do, we are trying to work. It's a progressive work, and we need a lot of help and input into this. A model that we'll try to address, because in our work over time, we have recognized that especially the diagnostic errors and the medication errors. If you have, if the health workers, through sustainable, continuous education, can be trained in the management of basically the common diseases affecting the people in the community as a starting point, collecting data in that area, and then training them to ensure that they are able to diagnose properly, prescribe properly. We think that these medication errors can be mitigated. During last year, we had a World Patient Safety Day sessions with the health workers in a number of health facilities at the lower level. But what came glaringly was the fact that they lacked information, they lacked knowledge on treatment of different diseases. Some of them didn't even know clinical guidelines existed, had never even looked at them. They were talking about the numbers. So you realize that also leads to polypharmacy, because someone is not really aware of how to diagnose this situation and just gives them, medicines, antibiotics, then maybe it could be malaria, and gives for malaria, all those, trying to capture all those. So it requires continuous professional development for this, and we are trying to see how we can work with partners to ensure that at that lower level we have at least the common diseases identified, but also it's the diagnosis and treatment, but through continuous development programs. I think that, for me, collecting this data, working with the village health teams to collect this data would help a lot in mitigating this.
Are your physicians open to such training? Because many times what I hear from physicians, both Dr. Alhawsawi and I know physicians' mindset, that this comes into the play. What are you trying to teach me? I think I have gone to school and I have done a lot of training and I know what I need to do. What is your perception of that mindset?
Like I said, in our experience and in our work, we have worked a lot with these healthcare workers, especially at the lower level facilities. And indeed, in our reports and in these meetings, they've acknowledged the fact that they're not well updated. And some actually accepted that the guidelines, I'll give an example of the clinical guidelines on prescribing. Some of them say they've never accessed, and they actually requested us to ensure that we bring this information. They get continuous, information on up-to-date information from, so that they familiarize themselves. But obviously, like you have said, some senior professionals think they know more, so that's why they don't even update their information, because they think they know. So that is a problem to the patient, because knowledge keeps evolving, new information, new knowledge on medications. So if they always think that they know and don't update themselves, it's a problem. But at least we are lucky to be having that working relationship with all these health workers, who actually some acknowledge that these trainings with them will actually make a difference.
Dr. Agrawal?
Oh, thank you. So we obviously, there are these three harm areas: medication errors, diagnostic errors, and hospital-acquired infection. Many times, physicians, patients, healthcare professionals, hospital administrators don't even think of them as significant problems. They are busy taking care of surgeries and operations and so on and so forth. How do we get the patient safety and the issue of harm, healthcare-related harm, on everyone's mindset? What are the barriers there, and how do we mitigate those barriers in your context?
Yeah, in my context, and to be honest, my experience is when I became a patient safety champion in 2011, in this meeting, we had all these healthcare professionals. And after this meeting, I took it upon myself to engage them, because then I realized that the problem of patient safety was not only unique to me, but it was a global issue and needed, combined efforts. But believe me, it wasn't easy. It wasn't easy, because there's a way that they look at it as, you're coming to attack us, so it is being looked at as many times negatively. You're looking at us as, being responsible for all this. So through continuous engagement, advocacy, awareness, and commitment, passion is one thing that is very, very important. So raising awareness about this issue, engaging them. We have organized, because I made a presentation, because of my work in patient safety, I was invited to sit at the technical working group in Ministry of Health, one of the technical working groups on supervision, monitoring and evaluation. And I kept telling them about the importance of patient safety. And believe me, over time, it didn't take one day, it took years, but eventually I organized workshops with World Health Organization, the first patient safety workshop in Uganda, invited them. We worked together with WHO country office, WHO headquarters, and they were amazed to see that people had stories to tell. The health workers themselves had stories to tell about patient safety. So continuously advocating and raising these issues. So we eventually a partner came on board, and a patient safety survey as a result of that advocacy was developed. It is there, not so extensive to determine the extent of the problem, but we have a starting point, and a policy is being developed. I was part of the task force, again, that was trying to ensure that this survey can generate the data that we needed. Then again, we through this advocacy, we went ahead to organize patient safety symposiums with the health worker, with the Ministry of Health, regulatory authorities, supply chain organizations, and other providers. So it's a continuous, kind of to ensure that the culture, to ensure that patient safety is integrated through those engagements.
Do you hear a lot of static? Oh, that's better.
So can you hear me, Regina?
Hello?
Can you hear me?
I can, but there's a lot of static somewhere.
Rain. It's starting to rain in here.
Ah, okay. I love the sound of rain, though.
Okay, well, I think listening to Regina and having the chance to deal with her over the past years is really always gives you hope that one person who's not a clinician can actually push all these efforts in a country and beyond. So I think that is great to hear. And there's a lot of work that needs to be done, but I think it just takes one person to take upon herself or himself to kind of push the agenda forward. So obviously you've done a lot of work with from the community perspective, with patients for patient safety, with empowering patients and families. So co-production is key, especially when you have a weak healthcare system and kind of difficulties at the local settings. What would be the top co-production areas in Uganda that you would want to see happen that would promote the efforts of patient safety? Because you talked about what the Ministry of Health would do, what other parts from the provider side, from the clinicians. What about the community, you know, the patients and families? What co-production tools do you think, if you were to pick three, the top three that you want to see in Uganda?
I think in terms of the side of the patients, I think it's advocacy and awareness. Then the other whole issue of the empowerment of the patients, and the awareness on patient rights and responsibilities would be, because you find that the lack of awareness on both parties, actually, the patients lack the knowledge on patient rights and awareness, so that prevents them to engage at an equal level, because they always think that the doctor knows it best, and and even when you try, the patient on the other hand tries to question, then they are looked at as know it more patient, kind of, and many times they're intimidated.
Troublemakers.
Yeah, troublemakers. I must say that many times I've been chased out of meetings and questioning that what is the patient going to bring on the table. So a lot needs to be done, especially in terms of engaging and empowering the patients, so that they can be able to advocate, they can be able to sit on those tables and talk confidently about, bring the perspective of the patient voice to those tables, because especially in our countries here, patients are really looked at as passive receivers of care with just a body, really, and no mind. So many times, one time I went to a meeting and we were trying to organize for a workshop, and I was advocating that a patient voice is included in this meeting. So it was a radiation meeting. So all these radiologists, senior consultants were looking at me and asking, okay, are you going to go to the hospital and bring these patients from their beds and bring them to our meeting? So I could not believe that at that level, they didn't even know that we had patient groups, that we had patients that empowered, patient advocates who can actually represent these patients in the hospital. But luckily enough, there was a professor who knew my work, actually through WHO contact in Geneva, who had told him about me. So he said, no, Regina can talk, but you could see the looks on their faces. So, but eventually we were allowed to participate in this meeting, and they really appreciated the perspectives of the patients. So there's a whole issue of advocacy and awareness, but engagement and empowerment through use of patient training guides, feedback system, peer-to-peer, interactions to ensure that the voice, the health workers on the other side understand that the patients have value to bring on the table, and actually without them the health systems cannot cope. And because they are busy, the patients see things that they can't see, and an empowered patient can actually make life better for them, especially support their work, and mitigate the patient safety impact.
So just to follow up on this, so do you need? Because this is an important area. Is it policy making that would help this happen? Is it having CEOs and directors at hospitals that would make this happen, or senior professors? Like, if you were to pick, what would be the biggest bang for the buck if you want to pick one area to focus most of your effort as patient groups? Is it with the Ministry of Health or trying to get policy legislated, or is it with the hospital management, or is it with the clinician group?
I must say that all of them are important, but I think the policy level is very critical. and like I told you, we've had successes. Although in our country, there's this joke, I don't know if you've heard about it, that Uganda makes the best policies and Rwanda implements them. Have you heard about that?
No.
I like Uganda makes the best policies and Rwanda implements them.
Yeah,
I
that's,
like that.
Interesting.
I'm writing that down, Regina.
yeah, so we have all these beautiful policies sitting on the desk and gaining dust, and then Rwanda comes and, just changes and puts Rwanda and implements them. So, but obviously the policy level is very, very key, because you always have something to, to refer to. Right now we have a patient rights and responsibility bill in offing in Parliament, so it's really about to be, enacted. So you'd have that tool to use, especially when it comes to incentives, to penalties. At least you have something to refer to. But then obviously, when we talk about the community level, the community people, patients and families do not care about these beautiful policies. They don't even know about them. What they want is, can they access self-care? Can they be heard? Can they be respected? Can they be, given the care that they need? So at that level, and the fact that they're looking at the healthcare worker as, as a God in himself, even being able to listen to them, being able to even greet them. I've asked the doctors that, what does it take to greet a patient when they come into your office? Because many times they're very busy, writing, you come in, you greet, they don't even respond to your greeting. Even a smile can make a difference. Communication is a whole big issue. How can we bridge this gap, the paternalism on the side of the patient who thinks that the doctor is a god, but also the doctor who thinks that he's a god himself? How can we?
That's right. I'm realizing all medical schools around the world have a standard curriculum, I guess. That produces us, I guess,
Yes. At that level, how can we even embed the medical curriculum on patient safety curriculum to ensure that they understand that because of their paternalism, because of thinking their gods are not allowing to listen to the patients, it impacts their safety. So that whole issue of that's where the healthcare professionals, the healthcare workers are very critical, because they're nearer to the patient than the policy. The policy is up there, but now the patient, right from the village health teams, because in Uganda we have the community health workers who are the first point of contact for the patient. How are they linked? In our model, we are trying to ensure that we empower the village health teams who interfaces with the patient every day. We have given them mobile phones to ensure that when something happens, they can call us, and then we ensure that we link these patients to the health facility, and also we have a contact person who is already stationed at a health facility, but very trained, knows how to respect and understand and listen to the patient, so that the patients can feel free to go to the health facility. Because many of our patients, they don't even go to the health facility because of that fear, because of the doctor knows it best. They don't listen to them. Poor woman is illiterate and cannot even, explain herself. But how can we create a sustainable model that makes sure that it goes all the way down to the community, and the person is able to, to engage with the healthcare service delivery system?
Dr. Agrawal?
Great. I really I've learned a lot, as to what happens on the ground level. So thank you. Speaking of policy, policy level, community level, bedside level, are there any regulations in place that say you must do 2 hospitals, that say you must do patient safety. For example, the Joint Commission or some sort of accreditation system or any system of financial incentives or disincentives to hospital industry that will promote patient safety.
Come again on that?
Is there any regulatory system? So, for example, there are bodies like the Joint Commission that work in the US that accredit hospitals. They look at certain standards to say, does this hospital meet these standards? And they say this hospital is accredited by an accreditation body. So many countries have these accreditation standards in place that certify hospitals, if you will, right? So they will say, yes, this hospital meets certain standards. Are there any such certification standards for hospitals in Uganda?
Yeah, there are, but like I said, there are so many challenges. I'll give an example of the professional bodies that are supposed to ensure that standards are made. Then we have on the other side also the national drug authority in terms of medicines. But the challenge is that these are there, but they're not well facilitated. They lack human resource capacity, they lack financial capacity to be able, so they are concentrated in the city. Some of them do not even have regional offices. So, for instance, when health workers, their licenses have to be renewed, they're supposed to have minimum, CPD points, but there's no system in place to ensure that that is done. So you find that even because of corruption and because of a lack of a system, many will get their licenses, renewed. Being monitored to ensure that what they are doing is right, is up to standard, is also a nightmare. You realize that it only concentrates mainly with the government hospitals through support supervision by the ministry. But again, because of the challenges that I've mentioned, but also the lack of interest and commitment, sometimes it's a lot of time is taken into doing accountability, making sure that accountability is made, as opposed to ensuring that work is done. So you find that there's so many gaps. There's so many gaps in that area. But then again, the private sector, private hospitals, which are mainly the biggest providers for healthcare, they're not monitored. They do their business. I'll tell you that one time I was doing a situation analysis on patient safety, and I went to most of these private, clinics and hospitals, and some of them were saying that once we opened, we had requirements to be followed. But it's now like over 10 years and nobody has ever come back to actually make sure that, these are implemented. And then I was asking them about patient safety, and they were telling me, oh, Regina, patient safety is expensive because we need more human resource for this. So again, like I said, the standards could be, those bodies are there, but they lack the capacity to do what they're supposed to do.
Absolutely. Thank you.
So you did mention it before in passing regarding reporting of adverse events. If you were to say out of 100% of the healthcare facilities in Uganda, how many do reporting? What percentage, roughly?
Actually, if it is advanced events, I must say that is a nightmare in terms of advanced events, because there is even no centralized system. Okay, National Drug Authority is trying to develop different applications. Right now there's a medication safety app, because initially it was the health workers that were supposed to report. But apparently they are very busy with a huge work overload, and it was initially paper-based. They have to, to write. So no reports were being received by the National Drug Authority. So now and also to say that the pharmacovigilance system is also very weak, very, not facilitated, with very limited skeleton staff, so they're limited to what they can do. Now, realizing the problem that there were no reports that were coming in, they're now trying to ensure that the patient is centered. And right now, this app is trying to ensure that the patients can also report. And I've been involved in peer-to-peer trainings to ensure that patients are reporting, the side effects and adverse drug reactions. But again, the patients are also the barriers that exist is the literacy levels. In one of the trainings, people could not even understand. We're trying to interpret to them how to use, their mobile phones to go to this app and use it and be able to send. It was a total nightmare. And now these we picked people we thought were a bit educated. So you can't imagine what would happen even at the lower level. So it's still a huge challenge, and the people that are doing a bit well, I must say, now these are the private not-for-profit providers. These like the IDI, the MALD, those. In HIV, they have the best practices. They're doing really well. But in these other areas, it's still a nightmare because of the reasons that I've talked about. So we need a centralized system, but we're still trying to figure out what would work best. That's why we like in Chain, we are trying to work out this model right from the community, because we understand better the community and how the challenges. They are not educated at that level. So how can we even have, collecting, that data right from there? These applications, they have challenges, obviously. The health work on the other side is very busy with 100 people, they call it working the lines, next. So they totally have no time to fill up those forms and even fill in those up, So it's quite a big problem in terms of reporting of those adverse reactions.
Dr. Agrawal?
In closing, I wish we had another 2 hours with you. That's how absolutely fascinating this conversation is. But in the interest of time, I think our closing question is, if you were to ask a burning question or make one most important solution to patient safety experts in the world, what would that be to save lives around the world and in Uganda?
In Uganda, my question, I think it was also from your side, how can we have people that are passionate and really care for the patient, genuinely care for the patient? They're not just doing it because it's their work, but have the interest of the patient at heart, not in words, but meaningful. For me, that's my frustration, because every time I see that the lack of interest, there's no lack of interest, there's no commitment, there's so much of what's in it for me. If there's no money, if there are no financial resources, nothing can be done, nothing can move. So how can we have people that are committed and genuinely care for the improvement of the system, that genuinely want the patient to be safe?
Thank you.
Great. Well, thank you very much, Regina. And again, what we're trying to do, as we mentioned at the beginning, is we want to look at the local context, because you and I have been to many, meetings, the WHO. Dr. Agrawal have been to many global meetings. There are sometimes we discuss these issues in abstract. And I think what we're trying to do is to figure out the situation on the ground. But then as we look at different local settings from West and East and North and South, we want to try to figure out what's, similarities and differences. and then maybe the summary of those, something that we can take back to the global experts for patient safety. Maybe we're thinking even about incentivizing a documentary movie producer to kind of produce a documentary about patient safety. But so we're collecting this as an ammunition to really try to bridge the gap from the local settings with the global expert, but also to help with the advocacy. And who knows, maybe we can end up with a documentary that could help promote this forward. So we'll keep the conversation going. I know that Dr. Agrawal has to leave right at this minute, but again, thank you very much for your time. I wish you all the best for your daughter, and let's keep in touch, through the phone and afterwards.
Okay, thank you so much. Thank you.
Thank you. A great honor talking to you.
Thank you. Thank you.